On the one hand, we have evidence that many nations are turning the corner on this virus. On the other hand, we have evidence that reinfections and low antibody titers could mean we're in for a much different battle than we thought. Hello, everyone. This is Chris Martinson here with your SARS-CoV-2 daily update, aka the honey badger virus, because this thing is very difficult to contain. If it gets in your body, it does a lot of damage, and it's proving to be a ridiculously sneaky foe in terms of trying to lock it down and figure out what it's doing. Lots of theories abounding. Let's get to them. This is day 76 of our reporting. I'm going to call this one reinfections because we have to explore that possibility. That's what we're really going to be focusing on here. But first, a public service announcement. Remember, every few days to try your jeans on just to make sure they fit. Pajamas will have you believe all is well in the kingdom. Got that off of somebody tweeted me that. I like that idea because there's two ways you're coming out of this quarantine period, right? Either ripped or fat. One of those two things is going to happen. So public service announcement from me. That's me. For anybody who doesn't know who I am, Dr. Chris Martinson. I have a PhD in pathology from Duke University. Here's a couple of papers I authored just for fun. Let's go to the numbers. These are April 7th cases. Today is April 8th, as I mentioned. Look at that. Well over 1,373 cases in the United States of new deaths. Over 400,000 cases. Look at that, 418,000. For all of you who are watching, a month ago even, or 2 months ago, when we had like 60 cases or something, this would have seemed like an impossible number. 17,000 in one day, new cases showing up in the United States. At one point, that was more than the whole world had. And so that's the nature of an exponential virus like this that explodes without any herd immunity to block it across a population. And this one's gone across the entire world. So a couple of things we need to start focusing on here for sure. When we look at the total number of recovered cases, it's just a skinny fraction of the total cases here. Active cases, very much larger than the total recovered. So this is going to hang around for a long time. And this is the thing about this virus. It takes a really long time to recover from and be cleared from. And I'll give you we'll look at the Diamond Princess, the Disaster Princess, a little later just to bring that forward. But the good news is Italy, France, Spain all seem to have turned the corner on bringing down the numbers of new cases. Still, those are pretty high numbers, but they've managed to bring them down. And how did they do that? Well, with a lot of very active NPIs, non-pharmaceutical interventions such as quarantines, lockdowns, shutting schools, banning mass gatherings, things like that. As well, individuals, it's up to the individual really to make this sing. So people have figured out how to be safer with hand washing, social distancing, and of course, wearing masks. And it's very exciting to see that wear a mask thing catch on and go all across the world. But gotta say it, what we're really doing is we're getting back to 1918. Remember all those tents that they put out in the fields, and then everybody had a mask on, even if they were just cotton masks. But that's what they found in 1918 with the Spanish flu actually worked, was something about being outdoors. Of course, if you have an aerosolized droplet and you're outdoors, those tend to get carried away and not be in a concentrated, contained, enclosed form like you would find inside, particularly in an AC system with the right temperature and humidity, so that those can pass more easily. Being outside seems to confer some sort of big advantages. Maybe, I don't know, maybe it's just that you're outdoors where the sun is shining UV rays down, and as those little droplets float around, those UV rays are hitting the viruses and inactivating them. So we're going back to 1918, outdoors, and this is a good thing. Let's all get back outdoors again. Very excited to see in my local area lots of trailheads of local hiking places here filled with cars because during this quarantine, what are you going to do? Well, a lot of people are getting out and hiking, and that is really good. Otherwise, what can I tell you? We're just getting more and more cases in here, and it doesn't seem like there's a lot of value in just trundling through who's got what. So, moving on. I'm starting to see some really ridiculously misleading headlines. We can speculate as to what the motivations are of people to do this. But here's Josh Gerstein, and he has a lot of followers, saying, French hospital halts hydroxychloroquine treatment study due to cardiac side effects. That's the headline. So I'm like, well, that's interesting. Let me chase that down. So a little Google Translate and a click. And what we discover is this is the article he was referring to here. It says, let's see here. So they're asking, the question here is, how are these patients followed from a cardiological point of view, those who have hydroxychloroquine treatment with azithromycin? And they're not saying zinc. I really want to see the zinc in there. This really seems to be important. We have set up a 777 and H24 monitoring method. All the COVID sectors of the Nice University Hospital send us the patient's ECG recordings. We interpret them live and report anomalies to them, which predispose to toxicity, which then require a cessation of treatment. Has this ever happened? Yes, from the start of the trial, thanks to this ECG follow-up, we highlighted the major risks of a very serious accident in a patient, and the treatment was immediately stopped. All right? So A, singular. They did that for a very serious accident in a patient. All right. That's a very different sort of an outcome from this headline. French hospital halts the treatment. I don't know why people are doing this, but this is a theme, and it's happening a lot. And it seems to almost fall along political lines. It's bizarre, but it's not scientific. But if we could at least just not do the grotesquely misleading headlines. Josh, thank you very much. That would be really helpful here. Okay. This was posted by an ER doc who's been a longtime member and participant over at Peak Prosperity. Here's the link to get there. This is going to be in support of this hemoglobin attack theory that we were working on for the last couple of days here. And so what they did is they found a picture from an ER docs group discussing this topic, and that's this topic here. This would go with the attack on hemoglobin viewpoint by several non-structural proteins made by COVID during infection of human cells. What is it? Well, there's this greenish tint here in the serum. Maybe that's hard to see in this particular picture, but this isn't the normal amber-colored serum you might see, or very clear. It clearly has a greenish tint to it, and iron in an unbound form would confer a greenish tint like that. So that would be actually in support of this idea, and somehow that iron has gotten out into the serum. It's not down here bound up in the hemoglobin in the red blood cells. Of course, how would we figure that out? Well, we need to test. Clearly, I would hope somebody would take that serum and run it out through a mass spectrometer or some other device to see what's in there and see how much iron might be in there and what form the iron might be. And if you find Fe2+, Fe3+, Fe being the periodic table nomenclature for iron, if you find iron 2+ or iron 3+, then that would really begin to support this theory. So I found that interesting. Hey, I want to talk about stimulus, doing it right, the Canadian edition. Thank you for sending this to me. A number of you did this, and this is great. Canada hasn't seen unemployment rates higher than 20% since the darkest days of the Great Depression. I mean, just listen in for how profound this economic impact has been. It's just shocking to watch U.S. stocks just climb this giant wall of money that the Federal Reserve is printing and throwing at it. Who benefits from that? Well, the owners of the stocks. Who owns those? Hey, more than 50% of stocks are owned by just the top 1%. So at any rate, wonderful stocks are going up, but for the regular workers out there, worse than the darkest days of the Great Depression is where we're at. Yet at the end of the first day of eligibility, the first day, for the new emergency aid benefit, 3.5 million Canadians had applied for employment insurance or the new benefit. Nearly 1/4 of the Canadian labor force is currently out of work. And we're not done yet. This is just in the first day. So over the darkest days of the Great Depression, that's where we're at already. By Monday evening, the number of EI claims, employment insurance claims made since March 16th was, just 3 weeks ago, 2.72 million. There were 788,000 Canada Emergency Response Benefit applications made on Monday alone. These are staggering numbers, and it's a testimony to the unsung heroes in the public service that 2.38 million of the EI applications have already been processed. The money to buy groceries or pay rent for more than 2 million hard-pressed families is either in their bank accounts already or will be in the next day or two. That's how it's done. And by the way, they're just going to keep sending those checks out. This is how it's done. Remember, I showed you the schedule of payments in the United States where they didn't even have on the schedule that people were going to be paid until September in some cases, but really by the end of July. This, when days count and the household budgets are ruined, your checks are only months away. It's so bad in the United States. It's hard to actually just chalk it up to simple incompetence anymore. You have to chalk it up to something maybe a little bit darker than that. I don't know. All right, how about let's talk about doing it weird, the U.S. edition. This just came out in the LA Times. Hospitals say feds are seizing masks and other coronavirus supplies without a word. What? I don't even have, what? Wait, we better read on. That can't be right. Although President Trump has directed states and hospitals to secure what supplies they can, the federal government is quietly seizing orders, leaving medical providers across the country in the dark about where the material is going and how they can get what they need to deal with the coronavirus pandemic. Well, how come we don't hear about any reports of hospitals suddenly discovering big piles of materials? I mean, you could understand this if the government's maybe taking supplies from one area and giving to another, but I haven't heard a single case of a hospital saying, oh my gosh, the feds showed up and dumped a whole bunch of PPE and vents on us here. I haven't read that yet. Hospital and clinic officials in 7 states described the seizures in interviews over the past week. The FEMA is not publicly reporting the acquisitions. You could call it acquisitions or you could call it theft. Depends on your point of view, right? Despite the outlay of millions of dollars of taxpayer money, nor has the administration detailed how it decides which supplies to seize and where to reroute them, or even if they are being rerouted. So no information there. Officials who've had material seized also say they've received no guidance from the government about how or if they will get access to the supplies they ordered. Well, who would know better than the people who ordered the supplies, which supplies they need? What's the plan here? Seize all the supplies and then call people up and find out what they need and redistribute them? What's going on here? That has stoked concerns about how public funds are being spent and whether the Trump administration is fairly distributing scarce medical supplies. In order to have confidence in the distribution system, to know that it is being done in an equitable manner, you have to have transparency, said Dr. John Hick, an emergency physician at Hennepin Healthcare in Minnesota. And he helped develop the National Emergency Preparedness Standards through the National Academies of Sciences, Engineering, and Medicine. Yeah, you got to have that transparency. It's got to be done in a transparent, equitable manner. That's, of course, how it has to be done. Because, remember, the gold standard pandemic approach involves clear, consistent, transparent, frequent, and timely communication. I forgot to add in there, thou shalt not seize under the cover of darkness and secretly the supplies that hospitals need. That's just doing it weird. Look at this. Look, let's get the detail on this. This is just so weird. I don't even know what to do with this information. In Florida, a large medical system saw an order for thermometers taken away, and officials at a system in Massachusetts were unable to determine where its order of masks went. Poof. They just went away. How hard would this be if the feds are going to take this stuff? How hard is it to say we're taking it and here's what we're doing with it, but we've got it? Massachusetts just unable to determine where'd our masks go. So I've heard some of these states are now doing things like, hey, they figured out this scam or this thievery or whatever's going on here, and they've started to do things to ship things in secretly. I don't know. Just go to your prisons, talk to some of the drug mules and drug distributors. Find out how they got bales of marijuana in. Maybe you can get a few masks in the country that way. I don't know. Maybe they got some tips. Are they stockpiling this stuff? Are they distributing it? We don't know, one official said. And are we ever going to get any of it back if we need supplies? It would be nice to know these things. Yeah, it'd be nice. It'd be more than nice. It might be life-saving. Yeah. Peace Health, a 10-hospital system in Washington, Oregon, and Alaska, had a shipment of testing supplies seized recently. It's incredibly frustrating, said Richard DiCarlo, the system's chief operating officer. We had put the wheels in motion with testing and protective equipment to allow us to secure and protect our staff and our patients. When testing went off the table, we had to come up with a whole new plan. Yeah, frustrating would be a kind word for that. This is weird. This is just weird. It's all over the country. Stuff is vanishing. And I, again, haven't heard any reports of some other hospital saying, oh, we got testing equipment that came up. So the sense is the government's got a big warehouse of this stuff somewhere, and it has some other purpose behind it. So doing it weird, there's just 2 possibilities I can come up with, really only 2. Everything else is a shade of these 2. First, just really grotesque incompetence. Just the instincts of any bureaucrat is to seize power and materials because then they can have a plan for figuring out how to distribute it. Of course, the speed of bureaucracy is just a fraction of the speed of the honey badger virus. So that's one possibility. Grotesque incompetence. What's the other? It's malicious intent. These are the sorts of things. If I wanted to prevent a hospital from operating correctly or to be able to save patients, this is what I do. I would take their necessary equipment away and I wouldn't tell them anything about it. And that would be the last they would hear of it. I would just seize stuff. I hate to think that those are my only two possibilities, but if you've got other ones, let me know. Let's talk about doing it right, though, the Indonesian edition. I love getting emails like this. This one was really off the charts good. Don't know if it's entirely accurate, but I'd like to think it is, because what the heck, this would be fun. Please pass on my thanks to Chris. His videos have been an inspiration to start the Mask for Millions movement in Lombok, Flores, and Bali, Indonesia. Mask making was piloted by Disabled in Lombok and got TV media attention and pressure on the government to introduce compulsory mask wearing. Locals have already sewn hundreds of thousands of masks in Indonesia, and this will be stepped up to millions this week. Hundreds of villages are now working towards full 100% mask wearing combined with social distancing and hand hygiene. This will save millions of lives in Indonesia as local mask making spreads across the country. Here's a couple of links. Once again, many thanks for the work Chris and team at Peak Prosperity are doing. Hey, thank you, Rafiq. Thank you for the email, and I really hope we had an impact and we played some role in that happening. That would be absolutely wonderful, because that's why I'm doing it, is to have an impact like that. And I love hearing that logic and reason can actually break through and be picked up. I don't know what to do with this information. It's just bizarre. I don't know what to do with paychecks, with so-called $1,200 stimulus checks coming in July. I don't know what to do with any of this. I don't know where to place it, and that's a really uncomfortable feeling for me. All right. This was a big uh-oh here. A lot of you sent me this, and thank you very much for pushing this my way. This comes out of South China Morning Post, by the way, for those of you wondering or don't know, that's a Hong Kong newspaper. And so I consider them independent from China itself very strongly. I've gotten really good stuff out of South China Morning Post. In fact, they had some of the best early coverage of this, and I'd cited a lot of articles out of SCMP at the time. All right. So low antibody levels raise questions about reinfection risk. This has been something we've been worried about for a while, so we're going to talk about this today because it's really important. Scientists in Shanghai say some recovered patients, show no signs of the neutralizing proteins, meaning antibodies. Early stage findings could have implications for vaccine development, I'll say, and herd immunity. Yep, you're right about that. This came out last night on April 7th. So let's burrow into this. Here's the link. And again, we'll provide all the links at the bottom of this so you can just click and go. All right. This is, I'm just taking different cuts of this. So this is a clip number 1 here. So again, from this article here. All right. Researchers in Shanghai hope to determine whether some recovered coronavirus patients have a higher risk of reinfection after finding surprisingly low levels of COVID-19 antibodies in a number of people discharged from the hospital. A team from Fudan University analyzed blood samples from 175 patients discharged from the Shanghai Public Health Clinical Center and found that nearly a third had unexpectedly low levels of antibodies. Nearly a third. That's not good. That's an uh-oh right there. In some cases, antibodies could not be detected at all. All right. There's a couple of possibilities that come to mind right away for why this might be the case. So remember, there's a couple of ways that you could have been diagnosed as having had COVID early on, particularly when they didn't have enough tests. One was you actually had the PCR test, so that's testing for the RNA of the virus itself. And if you got a positive off of that, that was considered you were to have been COVID positive. Another way, China's doctors were really relying on a lot of clinical symptoms. They would use a CT scan they thought was even better and more predictive, more accurate than the PCR test itself. And the CT scan, very quick, take a picture of the lungs. If they saw those ground glass opacities, bilateral, both lobes, both sides, both lungs, then they would say you were presumptive positive. So what's possible here? Well, one possibility is that either there were some false positives then, so people were being recorded as being positive then, but they actually weren't, and they never had COVID. So when you test for antibodies now, you're not seeing any. Why? Because they never had COVID. They were always without COVID, but we had a false positive. Or it could be false negatives. Now, maybe the antibody test itself is giving a bad reading here. Maybe it's not a sensitive enough test, and it's got a low sensitivity, so it's failing to identify those with the disease. Okay, so you get what's called a false negative. So one of those two things could be that's always possibilities here. So I just want to make sure we're keeping everything in mind. Let's go on to another set of clips here. Although the study was preliminary and not peer-reviewed, very important, it was the world's first systematic examination of antibody levels in patients who had recovered from COVID-19. All right, that's extra information. All the patients had recently recovered from mild symptoms of the disease, and most of those with low antibody levels were young. Now that's interesting. Most of those with low antibody levels were young. That raises a number of implications. I'll get to those in just a second. The researchers excluded patients who had been admitted to intensive care units because many of them already had antibodies from donated blood plasma. So, this is interesting because we knew that they were doing this plasma therapy where you take blood plasma out of people who've already recovered from their bout of COVID-19, and then that has circulating antibodies, and you give the plasma to a sick person. Here they're saying people who had been admitted to intensive care units, many of them had already had antibodies from donated blood plasma, many of them. So it sounds like this wasn't just like they tried it and it sort of worked. Like they were giving this plasma therapy to a lot of people. So glad to hear that, glad to know that. I'd like to see the clinical data to find out how well that worked. The researchers said they were surprised to find that the antibody titer, that's the level, that's titer is the word for the amount of measured antibodies in a given volume of plasma or blood. The given antibody titer value in about a third of the patients was less than 500, a level that might be too low to provide protection. So they had it, but it wasn't like, yes, you have them, no, you don't. There was a range that they would have. And so a third of them were below that 500 level. About 30% of patients failed to develop high titers of neutralizing antibodies after COVID-19 infection. However, the disease duration of these patients compared to others was similar. So it wasn't like, if that's important, because if it turned out these particular people who had these low antibody titers had a very long progression of the disease, it was with them for weeks and weeks and weeks and weeks, you could chalk that up and correlate that and say, well, that's because they had a weak antibody response. They weren't really fighting it off, so therefore they had a long disease progression. But mysteriously, this honey badger virus is just such a mysterious foe. Mysteriously, what we're seeing here is that they had about the same disease duration, but they didn't develop antibodies. They got better, and now what? So this raises a whole host of complexities about this, about how we treat this, and all sorts of implications from this. This is a clinical observation we made at the front line. What this will mean to herd immunity will require more data from other parts of the world. Professor Huang Jinghei, the leader of the team, said on Tuesday. That's code speak for this has really profound implications for herd immunity. And if people get this but then don't develop immunity, herd immunity is going to take a lot longer to get to. All right, so that was very delicately worded by the professor there. Professor Huang said 10 of the patients in the study had an antibody presence so low it could not even be detected in the laboratory. So that's 10 out of, what I remember, 175. So what's that? Maybe just a little over 0.5%. So, but yeah, that's, if you can't detect it in the laboratory at all, a couple possibilities here. Again, they could have been a false positive once upon a time, never been exposed to it, so therefore they don't have antibodies now. Or, I don't know, maybe some people just don't develop an antibody response at all. These patients experienced typical COVID-19 symptoms, including fever, chill, and a cough, but might have beaten back the virus with other parts of the immune system, such as T cells or cytokines, or maybe macrophages, right? How they did this, still unclear. Vaccine developers may need to pay particular attention to these patients, Wong said. If the real virus could not produce antibody response, the weakened version in the vaccine might not work in these patients either. So yeah, that's why we have to do the clinical data and testing of vaccines. There's going to be a lot to learn. It's not as simple as yes, no, we just give a vaccine, it works, now people are immune. It doesn't quite work that way. So given all that, I felt, okay, I got to go back to the actual study here, because sometimes you learn just a little bit more going to the actual study. Let me expand that out a little so we can see it. So this is the study right here, and it says neutralizing antibody responses to SARS-CoV-2 in a COVID-19 recovered patient cohort and their implications. That's it. These, I tell you, you got to develop an appetite for reading papers like these, because the headlines are not the grabbiest, but good study. I like what they did here. So first, methods. Here's their methods. Plasma collected from 175 COVID-19 recovered patients with mild symptoms were screened using a safe and sensitive pseudotyped lentiviral vector-based neutralization assay. Spike-binding antibody in plasma were determined by ELISA. So that's an enzyme-linked immunosorbent assay. Very sensitive test. And by the way, the ELISA has been around a long time, very well known, very well characterized, lots of understanding about that. So this is a very standard test to run. So they're looking at spike-binding antibodies in plasma. So the spike protein, that's a very logical place for the body to develop an antibody against it. So they're looking for that particular antibody. And they were looking both the S1 and S2 proteins. So there's two protein subunits, and S1 and S2 on those spike proteins. So the levels and time course of SARS-CoV-2 specific, that's neutralizing antibodies, and the spike binding antibodies were monitored at the same time. Findings, this is findings now. SARS-CoV-2 NAbs were unable to cross-react with SARS-CoV virus. This is classic, as Dr. Rasmussen said the other day. SARS classic, like classic Coke. This is the original SARS virus. So this finding is kind of interesting. These neutralizing antibodies for SARS-CoV-2 did not cross-react with SARS-CoV itself. So that has an implication. You can't just develop one coronavirus vaccine and it kind of works on all of them. That's too bad. SARS-CoV-2 specific NAbs, neutralizing antibodies, were detected in patients from day 10 to 15 after the onset of the disease and remained thereafter. The titers, or amount, of neutralizing antibody among these patients correlated with the spike binding antibodies targeting S1, RBD, and S2 regions. So they're making sure here that these neutralizing antibodies, they actually they're targeting the things that we think they're supposed to be targeting. So all that worked out. That was pretty good. However, here's where it gets weird or interesting or complex. The titers of NAbs were variable in different patients. Elderly and middle-aged patients had significantly higher plasma neutralizing antibody titers, the p-value of 0.0001, very, very significant finding. And spike-binding antibodies, p of 0.0003, very significant. Anything over 0.05 is less than 0.05 is a significant finding. That means less than 1 in 20 random chance. These are, this 1 in 10,000 chance of it being having occurred randomly. So then young patients. All right. Notably, among these patients, there were 10 patients whose NAb titers were under the detectable level of our assay. So that was under a reading of 40. While in contrast, 2 patients showed very high titers of NAb with these intermediate findings of 15,989 and 21,567. So these guys were under 40. Look at the titers here, over nearly 16,000, over 21,000. So these would be the people you would say you would want to draw plasma from and then use that plasma for the antibody therapy that you would give to people who are desperately ill. That's why it's important. It's not just, you can't just take the plasma from anybody who's had it and recovered. Some of them would be completely useless. Some of them would be amazing. The neutralizing antibody titers were positively correlated with plasma C-reactive protein levels, but negatively correlated with the lymphocyte counts of patients at the time of admission, indicating an association between humoral response and cellular immune response. So positively correlated with CRP. So the higher the titer, the higher the C-reactive protein level, but the higher the titer, the fewer lymphocyte counts you would see in the patients at the time of admission. And vice versa, I'm guessing, when you go down to the low end. That's interesting. So yeah, we're going to take a while to unpack that and figure that out. All right, their interpretation. The variations of SARS-CoV-2 specific NABs in recovered COVID-19 patients may raise concern about the role of neutralizing antibodies on disease progression. Indeed, it does. The correlation of NAB titers with age, lymphocyte counts, and blood CRP levels suggested that the interplay between the virus and host immune response in coronavirus infections should be further explored for the development of effective vaccine against SARS-CoV-2 virus. Furthermore, titration of neutralizing antibodies is helpful prior to the use of convalescent plasma for prevention or treatment. Absolutely right. So you would want to take the titers first and then decide which plasma you were going to use. This all makes it a lot more complicated all of a sudden. So let's go through what are some of the implications here. And by the way, there's always the chance that, this ELISA test is looking for antibodies that are targeted against these spike proteins. It's possible that these low patients here, maybe they developed the antibodies against some other proteins on the surface of the virus, not the spike protein. And maybe that explains this. And so we would need to have another test finding out if these people had different antibodies in any way, shape, or form. But usually it's going to be the antibody response that's going to neutralize a virus like this is going to be ones that target its binding sites that allow it to get in through the ACE2 receptor into the cell. And those binding sites are on the S protein. So very logical that they were looking at that there, and it would be unusual, I think, maybe not unheard of, but unusual. I don't know. I'd have to talk to somebody who knows more about this, to find an antibody that targeted some other part of the virus and was still neutralizing. So I'm going to leave that as a possibility here. Implications. Okay, first, some younger people, they might be clearing the disease via a completely different pathway than we're used to, right? It's the normal response is the body sees an invader, sees an unusual protein, develops antibodies against that. The antibodies then trigger this whole immune response that then helps neutralize these particles and helps the body identify diseased cells. So maybe it's something else. Macrophages, T cells, cytokines, we don't know. Lots to learn yet about this particular honey badger virus. Very sneaky foe. It means that secondary infections are a distinct possibility now. So it's possible that people get this disease, leave the hospital setting, they don't have sufficient antibody titers, and then they get reinfected again later. Why? Because they don't have any antibodies to this thing and they have no defenses against it. That's now a distinct possibility. A third implication is maybe vaccines, they might not work or not work on everybody. We don't know. Imagine we give vaccines all over the place. We need to get 80% herd immunity, 80% immunologically competent people. But what if 30% of people just don't develop sufficient antibodies? Well, then we're stuck at 70%, even if we have 100% vaccination rate. So this is it's going to take time, and it might be that we have to come up with multiple vaccines because maybe some people need a different vaccine. We don't know yet. We don't know. Just a lot of uncertainty at this point in time. And finally, it's, developing herd immunity will be impossible if people don't develop antibody immunity and they can get secondary infections. But, maybe there's this different non-antibody dependent pathway for immunity. We don't know. So this would be a lot of interesting research and science is going to come out of this. What an astonishing foe with just 38 kilobytes of information packed in a little tiny lipid bilayer with a couple of spike proteins. Just astonishing, everything that's coming out of that little tiny package. All right. Well, this is starting to tie together now with some of the data we've been seeing for a while. We've reported on the secondary or reinfections for a while. This came out yesterday. More than 50 Korean COVID-19 patients test positive again. Health officials in South Korea are feeling stumped after dozens of coronavirus sufferers retested positive. In all, 51 victims from the south central city of Daegu and its surrounding province were diagnosed with the virus after being released from quarantine, stated the Korean CDC. office. So they were released from quarantine, and they were diagnosed with the virus after being released from quarantine. But there is one possible reason for the strange occurrence. The test results could be the result of reactivation of the novel coronavirus, health authorities said on Monday from the Capitol Sol. I don't know if I like that reason, reactivation. So that would imply what they're suggesting here is that people have it, but it kind of goes away. It's running really low. It's in your body, but it's at such a low level that it's not really detectable. So you're getting these false negatives. You should be getting a positive reading if you had sensitive enough test, but they don't. And then later, the honey badger virus reactivates and then comes roaring out for another pass. Jong Eun-kyung, the Director General of Korean CDC, asserted that the virus was most likely reactivated rather than people being reinfected after they tested positive a second time in a relatively short time after quarantine. That's not a good thing. So we're going to have to watch that, and maybe if we had more data, we would find out that these people also had the low antibody titers. Just guessing. I don't know. So that's not a very encouraging sign right there. And as well, we might draw something from the Princess Diamond story, the Disaster Princess story, because remember, let's look at the timeline here first. February 4th, we had the report of 10 people testing positive. They tried that really ineffective quarantine. Didn't work, probably because the virus was aerosolized droplets spreading through the air system in the hospital, in the ship, or possibly it was coming out in people's feces. And when they use those sort of explosive vacuum toilets that they have on cruise ships, the droplets were there being aerosolized. But however it worked, it spread all over that ship. And so over the next 2 weeks, hundreds of people tested positive until the ship disembarked. So that was over 2 weeks. Thus, the latest people could have been infected on that ship was February 18th. That's 49 days ago. So let's look at something here. There's still, as of April 7th, 82 active cases, 10 still in serious or critical. 49 days ago, these poor 10 people, if it's the same 10 we've been tracking for weeks and weeks, they've been in serious or critical condition for 3 weeks or more at this point in time. So, but just think about the case here now. So we have these cases where, people went into quarantine and then they come out and then later they retest positive. And we have these people who are, these active cases. Maybe some of these are just people who are continually testing positive and they haven't cleared this thing out. Maybe because they have low antibodies. We don't know. And remember, we reported this way back in February. I just want to call it back up again because this raises this other possibility that being reinfected might be bad if you're getting reinfected at all. So this antibody-dependent enhancement, ADE, this remains a strong possibility. Again, ADE stands for what happens in the dengue fever where your antibodies drop below a certain titer level, and then all of a sudden if you get reinfected with another serological strain of the dengue virus, that's a worse outcome because all of a sudden your body goes into a hemorrhagic fighting of that thing where your immune system goes haywire. The secondary infection is very bad, and it's called antibody-dependent enhancement. It's not a positive enhancement. That's an enhancement of a bad outcome because it's enhancing your immune system going nutty and attacking your own body. Chinese doctors sounding the alarm on the coronavirus, say the illness could be even deadlier for patients who catch it again, according to a report. The whistleblowing physicians working to fight the virus in Wuhan, the epicenter of the outbreak, revealed that medically cleared patients have been getting reinfected. So we had this data way back here, but we're seeing it again now showing up here in Korea more recently. So it's kind of a thing. We saw it in Wuhan. We're seeing it in Daegu. We're probably going to see it in New York City eventually. So it's highly possible to get infected a second time, only here now they're going to talk about the clinical outcome. So one possibility, the physician said that the medication used to treat the virus can have negative side effects on patients' heart tissue, making them more susceptible to cardiac arrest. A few people recovered from the first time by their own immune system, but the meds they use are damaging their heart tissue. And when they get it a second time, the antibody doesn't help but makes it worse, and they die a sudden death from heart failure. So here they're talking about that ADE possibility. I don't know if they had data for that or they're speculating. This is incomplete. We don't know that. So the doctor added the virus has outsmarted all of us since he says it's able to hide symptoms for up to 24 days. which contradicts current guidance that incubation period is 2 weeks. Again, I believe 24 days is the outer limit of this, so it happens in some cases, not all, but some. What's more, the infected patients often return false negatives before eventually being diagnosed with the illness. So, yeah, this is a sneaky honey badger virus. It hides out. All right. That's the data I have for today. The conclusion for all this, just plant a garden. I know the stock market's going up again today. It's been up for a few weeks. The Dow is like, put on 25, 30% by now. And that's all wonderful, but it has nothing to do with the reality of the situation, which is that you have 25% of people out of work in Canada, probably approaching a similar number in the United States. We just haven't reported it to ourselves yet. Very, very slow responses by all sorts of authorities, and a really, really sneaky virus that we're having to learn more and more and more about. So conclusions for today. For some reason, some people seem to want to downplay the HCQ zinc Z-Pack angle. Again, that zinc's got to be in there, I'm pretty sure, at this point in time. I'm not sure why these people are doing that, but it's a theme at this point in time. It's a thing. I don't know why it's there, but there it is. Greenish patient serum, suggestive of reactive iron. Well, that certainly needs testing. And another spelling error there. So let me just correct that right now because I don't like those. All right. So yeah, that all needs testing, of course. And some countries are doing it right, some are doing it wrong. But the U.S. is just being weird about this. I don't know what's going on. Stealing supplies from hospitals under the cover of night and, intercepting shipments and not telling anybody when they're coming. It's just that is just bizarre. And then, shoveling trillions of dollars to banks and hedge funds and the 0.01%, literally the 0.01% of wealthiest people, while slowballing really meager stimulus checks to the people who need it most. Just weird. Very odd. Okay, these low antibodies in recovered patients, that's a huge red flag for herd immunity hopes. If it turns out that we don't develop antibodies either in sufficient quantities or the titers decay really rapidly over time, like it does for the cold virus, which is a coronavirus, then herd immunity is going to be something that we're going to be redeveloping every infection cycle. So this means we really, really, really need a vaccine, and it's got to be a good one, and it's got to work on a lot of people. So let's hope for that. Reinfections. Okay, those seem to be happening for at least a few people. Is it a big thing? I don't know. I don't know yet. We don't have enough data yet. We need tons of data. We need to know what's the correlation between the titers and the clinical outcome and the reinfection risk, and whether or not people had a really slow burning variety of this, or whether the virus got reactivated. We don't know any of that stuff, but that data is all coming, and I can't wait for all that data to come. Rather than the U.S. government stealing medical supplies, I'm going to use that word stealing here. What they really should be doing is mounting one of the most aggressive data collection efforts ever. Massive database, collect it all. Don't wait for the harried doctors, physician's assistants, nurses, other healthcare providers to do that on their own. Collect it and share it, cross-correlate it. Use AI, use big data, use all that wonderful technology to start figure out what the patterns are, because this mysterious little 38 kilobyte package of information is proving to be smarter than a lot of big wealthy countries. That's all I have for today. Thank you for listening. We'll be back with you tomorrow.
Hi folks, Adam Taggart here. Chris Martinson and I are the co-founders of Peak Prosperity. If you want to get alerted whenever we release a new video from Chris, just click the red subscribe button right beneath the YouTube video player. Once you've done that, a little bell icon will appear right next to it. Click on that bell. It looks like this. And that's it. The next time we publish a video from Chris, you'll immediately receive a notification from YouTube. Thanks for watching our videos.